Very warm welcome on our Lunch and Learn for the London Centre for Work and Health, and we are absolutely delighted to have Dionne coming to talk to us this morning. It's a topic that I think many of us are interested in, and I think very few of us are specialists in. So really delighted that you're coming to share the work that you've been doing. So Dionne is at King's College London. She studied her PhD there and is now a research associate with the UKRI Population Mental Health Consortium, which is a bit of a mouthful. Maybe you've got a different way of saying it. But really looking forward to hearing about the insights that you're working on, and particularly looking at that big data piece and what we can really learn from some of those interplays between how people are managing alongside universal credit and PIP, and what that means for various outcomes in life and economic stability as well. So over to you. Thank you.
Thanks, Jo. So thank you for that introduction, and probably saves me a slide or two, to be fair. I understand that I have up to about 30 minutes, but I probably won't use all that time, and it would be great to get some feedback from the audience today. So as my slide indicates, I will be basically presenting some findings on the associations that I've found between receipt of state benefits and mental health among a cohort in contact with secondary mental health care services at the South London and Maudsley. So I won't go through this because Jo has helpfully introduced me, but in case anybody's interested, the slides can be shared after the presentation. But a lot of my research interest tends to fall in health and ethnic inequalities, social determinants of health, and I work alongside my colleagues, Dr. Sarah Ledham, Professor Sharon Stevelich, and Professor Jay Dasmunchi at the consortium. This is just a brief overview of the content that I intend to talk through today. So I will provide a little bit of background or rationale for the research. I will talk through the methodology, the initial findings, and some of the conclusions that we could potentially take away and discuss today. So in terms of the background, at the moment, the UK unemployment rate stands at about 4.7% among individuals aged 16 and over, according to statistics provided by the Department for Work and Pensions. There has been a rise in working age benefit claims. So working age, we mean people aged between 18 and 66 years old. Around 86% of benefit claimants or recipients reported a mental health condition, even if that mental health condition wasn't the main reason for them receiving the benefit. In other words, these claimants were probably receiving benefit for a physical health condition, but also reported a comorbid mental health condition. And I think around another 19 to 20% reported that they were actually receiving benefits for a mental health condition. And it's particularly interesting time because we've seen some major changes in working age benefits over the last decade with the introduction of universal credit and personal independence payments, which replaces the disability living allowance, and universal credit is streamlining some of the other means tested benefits into one monthly payment. We've seen see more stricter eligibility criteria as well in terms of how benefit recipients can receive their state benefits. They have to meet some conditions or criteria in order to receive them. And there has been some reports more recently of increases in sanctions and suspensions. And a recent report by the OECD said that basically the UK had one of the strictest conditionality regimes amongst the OECD countries, second only to Malta. So in other words, people with UK benefit recipients tended to have more stricter criteria for accessing benefits in terms of looking for and accepting work. So just a quick overview of the two benefits I was actually looking at within this research. So personal independence payments are essentially a disability benefit that was rolled out in around April 2013 under the Liberal Conservative Coalition government. The PIP replaced the legacy disability living allowance, and that money is used to cover the additional costs of disability or long-term illness. PIP is also made up of two components. So there's one called the daily living component, and this is for extra help that someone may need with everyday tasks, which can include preparing food, washing, getting dressed, and so on. And the second component is the mobility component, which is the extra help that somebody needs to actually get around. So this could include planning a journey or following a route. And most importantly, this benefit is actually not means tested. So in other words, it doesn't matter how much somebody makes or has in say somebody makes, so that it's you still receive this particular benefit. Oops, is it moving? There we go. Universal credit is another benefit that was rolled out in 2013. It is means tested, so the amount you receive depends on the income you currently receive. It streamlines 6 separate means tested benefits and tax credits, which includes job seekers allowance, housing benefit, and child tax credit. And those benefits are streamlined basically into a single monthly payment if somebody is out of work or on low income. So the personal independence payment, so research on these associations, so my colleague, I'm not sure if she's here today, but Sharon Stevelin conducted a study using a data linkage between the Department for Work and Pensions benefits data and the secondary mental health data at South London and Maudsley Trust, and looked at the profiles of people within accessing this service in terms of the profiles. So around a quarter of the people in contact with secondary mental health services were in receipt of this particular disability benefit, and this receipt was higher in old patients, those with severe mental illnesses, among Black and dual heritage groups, women, patients in more deprived areas, but it was interesting that there was a lower receipt amongst Asian and other Asian British groups. Another study that used the benefit data from the DWP found that actually people with mental health diagnosis were like almost more than twice as likely to lose their disability benefits when transitioning from legacy to newer benefits than those without physical health conditions. Other research looking at universal credit and mental health more specifically, again, so my supervisor Sharon found that around using a similar sample, found that just over 26% of people in contact with secondary mental health services were in receipt of this benefit, and a higher receipt was noted for younger patients. Lower receipt, those without a severe mental health diagnosis, that looks a bit confusing there. Among Black ethnic groups, male patients and patients in more deprived areas. And another study found that prevalence of self-reported psychological distress was increased by just over 6 percentage points among those receiving universal credit using the UK Household Longitudinal Survey data. So given this background, what we were really interested in was, well, in terms of people with mental health disorders, what is the actual association between these disability benefits and out of work benefits, with 2 specific outcomes, one being mortality and the other being inpatient psychiatric admissions? So how does it affect service use and adverse outcomes like mortality? And I'll just go through the method very quickly. So again, props to my supervisor, which took her years, bless her, to get this data linkage underway. But we had the first ever linkage of electronic health records with benefit records in the UK using CRIS data from around 2007 to 2020. So those are de-identified electronic patient records held by South London and Maudsley that were then linked to administrative records from the Department for Work and Pensions dating from 2005 to up to I think around June 2020. So around 400,000 individuals who access these services in South London were linked to benefit data from the DWP. So the observation window from this study was from 2013 up until June 2020, and there were 2 separate analyses looking at these 2 specific benefits. So we can see there's a slight difference in terms of the cohort sizes for each of those analyses. So for those, for the first one, it was just over 146,000 for the disability benefits or personal independence payment cohort, and among those with universal credit, it was just a little over 140,000. The eligibility for this study was that they needed to be of working age, so that would be between 18 and 66. They needed to have lived in the UK and needed to have had their records linked with the DWP, so they needed to have a national insurance number. The two outcomes, as I mentioned before, of interest were mortality within that study observation window, and also a first inpatient psychiatric admission to SLAM services within that period. And the main exposures were the receipt of either PIP or UC. Within that data as well, we had access to a number of socio-demographic and clinical indicators, which included age, sex, ethnicity, area deprivation, mental health diagnosis, history of admissions, history of receiving benefits among many, and a Cox regression analysis was used to analyze these associations. So for those of us who are maybe less familiar with survival methods, so Cox regression or proportional hazard regression is a method in survival analysis that looks at how different factors influence the time until the event of interest occurs, in this case, inpatient admissions or death. So the regression method estimates a hazard ratio, which shows how the factor changes the chance of the event happening at any given time. So as we can see here, when the study starts, we have the cohort members, we follow them up over time until we either see death or admission, or if they survive until the end of the study. So the findings from the universal credit analysis, firstly. So for the descriptive statistics, we can see here that just over 2% of the sample had died in that study period, and there were slightly lesser deaths, ever so slightly lesser deaths, proportion of deaths within those who were receiving universal credit compared to those who weren't receiving this particular benefit. And then we had about 1.8% of the total sample experiencing a first inpatient admission within that study observation window. And again, so with the universal credit receipt, we can see that there was a slightly higher proportion of people being admitted, for having a psychiatric admission compared to those who weren't in receipt of this benefit. Similar levels, proportions of people compared to the previous profile study conducted by my supervisor. So we can see about just over 26% of individuals at this time were in receipt of universal credit, and a high proportion of UC receipt was noted among those aged between 25 and 34, male participants, white British groups, those living in more deprived areas, and participants who had a diagnosis of a drug or alcohol disorder, and those with other depressive disorders. So in terms of the first association, so receipt of universal credit was seen to be associated with a higher risk of inpatient psychiatric admissions. So in the unadjusted models, that amounted to about 56% higher risk among those with receiving universal credit who were more likely to be admitted during that time period. But when we adjusted for the socio-demographic and clinical covariates, that slightly decreased, but it was still going in the same direction, i.e. that there was more of a risk of an inpatient psychiatric admission among those who were receiving universal credit. And the information below was just kind of the markers. So looking at the other individual level socio-demographic and clinical covariates that were associated with these admissions. And a lower risk was noted among those who received legacy benefits, so those who were receiving disability living allowance. And among most psychiatric diagnoses, when comparing those to people with schizophrenic disorders, a higher risk of admission was noted among most ethnic groups compared to the white British cohort, and a history of legacy benefits seemed to be also linked to a higher risk of admission within this cohort, but there were no associations noted for gender. And among universal credit and mortality, so overall, there were no associations observed between receiving universal credit and mortality. However, markers of other socio-demographic and clinical covariates linked to mortality were a lower risk of mortality among females, among some ethnic groups, which included the South Asian and Black African populations, those with anxiety and depressive disorders compared to those who were diagnosed with schizophrenia, and a higher risk of mortality among older age groups, those with prior history of admissions, those, oh, sorry, I put that in twice, excuse that, but those who had legacy benefits and those diagnosed with intellectual disabilities. So this largely maps on to some of the research that has been done looking at some of those socio-demographic and clinical covariates already. And that was a very exploratory interactions analysis, which I would take with a pinch of salt, just because of still trying to sort of understand what may or may not be going on. But with these interactions, it's going in the direction of those with drug and alcohol disorders seem to be more at risk for admissions than compared to those with schizophrenic disorders who were also in receipt of universal credit, and a lower risk of admissions among those in receipt of UC, among those who identified as Black Caribbean or other Black, compared to their white counterparts, essentially. But for this one, there were no other associations observed for age, sex, and area deprivation. But as I said, as this is still quite exploratory, please do take these interactions with a pinch of salt. The findings for personal independence payments. So in this case, there was about 3.2% of the sample had died within the observation period, and there were more deaths among those who were receiving this disability benefit than those not in receipt of this benefit. Around 3% of the sample had experienced a first inpatient psychiatric admission during the observation window, and it was noted that there was a higher proportion of those among those receiving personal independence payments compared to those who weren't receiving this benefit. Just over 25% of individuals were receiving PIP, and a high proportion was noted among participants aged 45 to 44, among white British groups, those living in more deprived areas, and participants diagnosed with schizophrenic disorder. And what was noted was that there was a similar proportion of the receipt of this disability benefit between men and women. The receipt of PIP was associated with a higher risk of inpatient admissions. So in the unadjusted models, the hazard ratio was about 2.71, but once we adjusted for the socio-demographic and clinical covariates, this reduced to 1.92. And in terms of, again, with the socio-demographic and clinical covariates, so a lower risk of admission was noted amongst those who were in receipt of legacy benefits. Most other psychiatric diagnoses, such as depression and anxiety, compared to those with schizophrenic disorders. A higher risk of admission was noted among most ethnic minority groups, those with a history of psychiatric admissions, and those aged between 25 to 24, between 25 and 44 essentially, but no associations were observed for gender and area deprivation in this case. And in terms of PIP and mortality, so we noted that there was a higher risk of mortality amongst those in receipt of PIP. So once we adjusted for the socio-demographic variables, there was about, and my math is absolutely going to be shoddy on this one, but around about just under 40% risk of mortality among people who were receiving personal independence payments during that period were at risk of mortality. And again, some of those socio-demographic and clinical covariates linked to mortality in this case was, again, a lower risk among women, a lower risk among most ethnic groups, apart from the white Irish group, among most psychiatric diagnoses and those living in less deprived neighbourhoods, and a higher risk of mortality were noted amongst those who previously received legacy benefits, those who were diagnosed with drug or substance misuse disorder, compared to those diagnosed with schizophrenic disorders, but no associations were observed with age. Again, these interactions should be taken with a pinch of salt, as I'm still exploring them, but essentially there seemed to be a higher risk of admissions among those in receipt of this disability benefit if they were diagnosed with other mental health disorders compared to people with schizophrenic disorders. Again, I'm not sure about this one, but I will check that one again. And a lower risk of admissions amongst those in receipt of PIP in older age categories, and amongst those who identified as female compared to the male population. So in conclusion, what can we actually take away? So the findings doesn't necessarily mean that PIP or universal credit causes admissions or mortality. It's probably more likely that PIP is a marker of underlying severity or complexity and need. So those who are in receipt of these disability benefits are probably also more likely to have other underlying factors which might make them more likely to die earlier than their other peers. We must also take into consideration the socio-demographic and clinical factors that may have a role to play in this complex relationship. So we probably still should be continuing some of the other individual level interventions to kind of manage those socio-demographic and clinical risk factors, as well as thinking about more policy level changes. The low risk of psychiatric admission among legacy benefits in some of these models may reflect that some of these patients may have had longer standing support arrangements and therefore might not actually need inpatient admissions at the time. Also, we cannot overlook the fact that there may be residual confounding within these models. So although all efforts have been taken to kind of include all potential individual level covariates and other socio-demographic factors within these models, there are likely to be other factors that we couldn't include the models for various different reasons. And PIP tends to target those most in need, but populations with complex mental health needs are probably likely to require more sustained clinical and social support going forward. And so this sort of wraps up my presentation. So a big thank you to my team and the funders of this study, but also I would also wanted to share this upcoming workshop. So I was awarded some seed funding from the King's Population Health Institute to run a couple of workshops looking at the factors linked to benefit receipt, work and welfare in ethnic minority communities. And we're particularly keen to hear from people with an interest in this field, whether from a professional perspective or perhaps from personal experience. So do please, you can scan that QR code and it will take you to a page which will help you register your interest in attending the workshop on the 8th of April, or equally you can pass that link on to other interested parties. And that's it. So thank you for your time and I'm open to questions.
Wonderful.